Hi, my name's Katherine Grantham. I'm a critical care and GI surgery dietitian at St. Francis Hospital in Tulsa, Oklahoma, where I primarily work with IBD patients in a perioperative setting. I'm very grateful to IBD Journal Club for the invitation to present this month. The article I chose is titled A Retrospective Cohort Study, Preoperative Oral Enteral Nutritional Optimization for Crohn's Disease in a UK Tertiary IBD Center, which was published in June of this year. Despite recent advances in therapy, we know that up to 80% of patients with CD will require surgery during their lifetime, with 20% requiring reoperation after 5 years. We also know that there's a higher incidence of surgical complication among patients with Crohn's. The reasons for this are multifactorial and include several that I've listed for you on the screen. Exclusive enteral nutrition, or EEN, is defined as provision of a patient's daily nutritional requirement with a liquid formula while excluding all other food and drink other than water. In addition to providing nutrition, EEN has been shown to induce and maintain remission in CD. This has been shown in a preoperative setting where EEN has been shown to enable deferment and potentially complete avoidance of surgery, as well as reduce complications post-op. However, the sample sizes for these studies have been small. As a result, this study aimed to evaluate the association between preoperative oral EN and postoperative complications among a larger cohort of patients. Patients undergoing ileal or ileocolic resection or strictureplasty at a single tertiary care IBD center in the UK between September of 2008 and March of 2020 were included in the study. Patients were excluded if they required emergency surgery for GI perf or complete bowel obstruction. Additionally, patients who required parenteral nutrition from the outset of the optimization period and patients with eating disorders were also excluded. All patients who met those inclusion criteria and were commenced on EN were assigned to the per protocol or PP group. This required them to be EN tolerant or able to meet at least 600 kcals per day for 2 weeks or more and not require any PN. The PP group was split into the EEN group, where EN provided at least 75% of needs and all other PO intake was discouraged, and the PEN group, where EN provided at least 600 kcals per day and up to 75% of the patient's needs, where the remainder was supplemented with any form of a normal diet. There was also the intention to treat, or ITT group, which included patients from the PP group, which required supplemental PN after that initial 2 weeks. And finally, the non-optimized group, which included all other patients which were excluded for reasons listed on the screen. The primary outcome measure was 30-day post-op complications. This included all complications, including surgical, non-surgical, and infective complications. Severity of post-op complication was classified per the Chladnian-Dindo classification, where the most severe complications are classified as a number 1. Secondary outcomes included frequency of specific complications, including some that I've listed on the screen for you. Finally, SPSS 25 was used to complete the statistical analysis of the tests that are listed on the screen. 300 procedures performed between 2008 and 2020 were included in the study. 5 cases refused EN from the outset and were placed in the non-optimized group. EN was prescribed in 204 cases for a median of 55 days, and this composed the initial ITT cohort. 142, or 69.6% of those cases, were confirmed to have tolerated EN per the definition of this study and were placed into the PP cohort. To the left of those boxes, you will see a few additional cases that were excluded. Of note, among the demographic data, the ITT cohort were younger at operation, younger at diagnosis, included fewer females, had an increased frequency of penetrating diseases and preoperative abscesses, as well as were more likely to be receiving biologic therapy and antibiotics, and were less likely to undergo open surgery despite no differences seen in the surgical procedure performed. Per univariate analysis, there was a lower frequency of complications of all kinds among the intervention, or ITT, and PP cohorts compared to non-optimized group, as well as fewer grade 1 and 2 complications. EN was associated with a reduced frequency in wound infection, prolonged ileus, and readmission. However, no difference in regards to unplanned stoma formation, length of bowel resected, or length of stay was seen. In conclusion, this is the largest reported cohort of patients with CD who've received oral preoperative EN, and the study demonstrated that it was tolerated among these patients during a pre-op period and strengthened the association between pre-op EN and a reduction in post-op complications. This is a retrospective study, and as a result, a randomized controlled trial is really needed to determine the optimum duration of treatment and the generalizability of effects. However, the population side of this study really does make it a promising first step in pre-op nutrition optimization for our patients with Crohn's disease.
Thank you all so much for your time. I'm looking forward to hearing your thoughts on this article.